Okay, well, since this is all the standing between most people in supper, I think you should probably start. My name is Michael Rieder from the University of Western Ontario, member of the BPS, member of the Canadian Society of Pharmacology and Therapeutics. On behalf of both those societies and IFR, I'd like to welcome you to this last symposium on teaching, training the next generation of clinicians in prescribing skills. The method of education has been described by one of my previous mentors as the process of casting false pearls before true swine. And while that might be a somewhat jaded view of it, it is nonetheless an important activity and something that we all engage in. So this session is going to focus on something that clinical pharmacologists pretty much everywhere do, which is helping to train the next generation of clinicians. So we have a series of 4 speakers, our first of which is a previous mentor of mine, my first supervisor actually in grad school, Stuart MacLeod. And I would note for the other speakers who are British, I think that of the speakers today, only 2 of them have FRCPCs from Glasgow, and that's me and Stuart. Just saying. Okay, so Dr. MacLeod originally qualified and trained in internal medicine, then did clinical pharmacology. He's founded pharmacology, clinical pediatric pharmacology at Sick Kids, was the division head there for a long time, then abandoned honest work and became a dean at McMaster. Following his deanship, he then went on to be the director of research, head of research institute at UBC. And after a long and very distinguished international career in pharmacology and therapeutics, finally retired, but remains very impactful in our society. He's a fellow of the Canadian Society of Pharmacology and Therapeutics, fellow of the College in Glasgow. And he's going to talk to us about the compelling need for better integration of science and clinical decision-making on pharmacology teaching. And with that, it's my pleasure to introduce Dr. MacLeod.
Thanks very much, Michael, and thank you for inviting me to present this afternoon, and thanks to all of you for making a sizable audience at this point in the meeting and late in the day. I'm going to give you a very general introduction to this topic. Whoops, maybe no, what do I do? No. Okay. Why does it not come up? There it is. Okay. Yes, I'm going to give you a general introduction. I'm going to talk a little bit about history and a little bit about philosophy, and maybe give you a few random thoughts on pedagogy and the pedagogic process. And I think I should say at the outset that in spite of the title, I'm not going to talk just about the medical curriculum. As Michael has already told you, I think I was the Dean of Health Sciences at McMaster, so I had responsibility for medical undergraduates and nursing undergraduates and rehab undergraduates, and I really believe that many of the principles that we're going to talk about this afternoon can be applied across the health professional spectrum, not just restricted to medical undergraduates, although much of the work that's been done has certainly been in medical curricula. This is my Chinese phase. I just like the sign that says, "Take good care of historical relics." I started out in pharmacology as an undergraduate medical student about 60 years ago now, working in a lab at the University of Toronto, and so I think I qualify as a historical relic. These are the perspectives that I'm bringing to this topic. As Michael has said, I'm trained in clinical pharmacology. I've worked in the field in internal medicine, I've worked in pediatrics, I've worked in addiction medicine, and because of my time at McMaster, I'm quite familiar with pharmacoepidemiology and what my McMaster colleagues like to call evidence-based medicine. My early training was in basic biochemical pharmacology. I did a PhD in looking at drug biotransformation in newborns. I've been involved throughout my career in undergraduate and postgraduate education. I was a dean of a faculty of health sciences. I've been the director of 2 research institutes. I've been a vice president of a health authority in British Columbia, and I've served on far too many public sector advisory boards in Canada, the United States, and the European community. So with that as introduction, we need to ask the question, what is the primary objective of health professional education? And some of you in the audience may disagree with me, but I think it's been generally accepted in the last 100 years or more that the objective is to graduate an undifferentiated physician. Sorry, I wanted to say practitioner, an undifferentiated practitioner. So it's not the objective of undergraduate education to teach people everything that they need to know for the rest of their lives, but it is the responsibility of those of us in undergraduate education to prepare our graduates to the point that they can undertake subsequent training in a number of fields. And in the case of healthcare, that may range from specializing in primary care to becoming focused, very sharply focused, in some cases on subspecialties. And of course, that kind of subspecialization is becoming more and more the norm as time goes on. You can't be a Canadian giving an international talk without quoting William Osler, who said that the training of the medical school gives a man, quotes, a man his direction, points him the way, and furnishes him with a chart fairly incomplete for the voyage, but nothing more. I think Osler also went on to say that to study medicine without books is to sail an uncharted sea. To study medicine without seeing patients is to never go to sea at all. So he had some wisdom 120 years ago. So I want to back up a little bit with the history and just remind all of you in the room where we've come from. In the 19th century, teaching of pharmacology and therapeutics to undergraduates was a fairly simple matter. There wasn't that much to teach, or certainly not that much that was known to be valid. Obviously, there were disciplines like materia medica and a very heavy focus on chemistry. I mean, you really couldn't get into medical practice in the 19th century without having a pretty good understanding of chemistry. And of course, that bridged on to toxicology and forensic science. As time went on, we developed more and more clinical chemistry techniques that helped with diagnosis. But I would say the 19th century generally was characterized by a rapidly growing understanding that there were interactions, biological interactions with chemicals from various sources of various kinds. I don't suggest for a moment that the understanding was very complete, but the notion was there, certainly. If we go back to 1900, back to Osler's day, at the turn of the 20th century, there weren't too many items in the therapeutic armamentarium. Digitalis, opiates, a few anesthetics that worked. A little bit was known about epinephrine, or I'm not sure, should I be calling it epinephrine or adrenaline in Glasgow? Either way, amyl nitrite, nitroglycerin was being used, salicylic acid. Actually, salicylic acid had been around for a few hundred years, although it was mainly being used as willow bark and concoctions of that sort. But acetyl salicylic acid was synthesized in the late 1800s. Ethyl alcohol, of course, disinfectants. Anyway, not very much. Pretty easy to design your undergraduate curriculum. And here's a cynical comment from Oliver Wendell Holmes in 1891 that pretty much sums that all up. I firmly believe that if the whole materia medica as now used could be sunk to the bottom of the sea, it would be all the better for mankind and all the worse for the fishes. easy to understand that sentiment. After 1900, for the first 6 or so decades of the 20th century, there was considerable progress. I mean, I'm sure at the time it looked like enormous progress, but as we look back from a perspective of 2023, we have to say it was pretty gradual, but there was progress in treating of infections. There were vaccines, there were chemotherapeutic agents like sulfonamides, antibiotics appeared in the 1940s, insulin appeared in 1922, I guess, as a Torontonian, I should know. Corticosteroids were gradually understood, but the progress was really slow. As we got into the second half of the 20th century, things sped up a little bit. There was considerable evolution in infectious disease and critical care management. Patients with sepsis started to survive in some circumstances. For pharmacologists in particular, there was an important recognition of hypertension as a prototypic disease that was very much amenable to pharmacologic therapy. This, of course, played on everything that had been learned about autonomic pharmacology and its implications for cardiovascular disease. Generally speaking, the treatment of cardiovascular disease, coronary artery disease, and congestive heart failure improved really dramatically, I think, in the 1950s and the 1960s when I started in medical school. And then we also had the beginnings of modern psychopharmacology, starting, well, I'm not sure where it started exactly, but chlorpromazine in the 1950s, benzodiazepines toward the end of the 1950s. There were suddenly tricyclic antidepressants. There were suddenly some drugs that at least had measurable effects in psychiatric diseases, and that was a big change. But altogether, in 1960, we weren't in a very good place for the teaching of pharmacology, or the teaching of meaningful pharmacology, at least, that was going to make a difference in patient care. But after 1960, we got into an era of really rapid evolution. I think this is a period I know quite well because that's when I was in medical school, but we really started to understand disease mechanisms in a better way. We had much better diagnostic methods. We had fantastic imaging techniques appearing, and of course they continued to evolve. And then more recently, in the last 3 decades at least, we've had this huge increase in our knowledge of molecular biology and molecular genetics. And all you have to do is look at the program for this meeting to understand the impact that has had on pharmacotherapy. Somebody who came to this meeting 50 years ago, as I did, wouldn't recognize the topics that are on the agenda for a meeting like this today. I mean, clearly, much of it is driven by molecular biology, by a better understanding of human genetics. And a big part of that has been that it's produced enormous progress in neuroscience and in immunology. And that has certainly changed the practice for most healthcare professions. This is a bit of an aside, but in 2023, there are now more than 1,000 approved drugs, at least in the Western world, approved in the Western world, 1,000 drugs that have specific pharmacogenetic conditions specified in the labeling. I mean, that's astonishing. I mean, 15 years ago, there would have been hardly anything. I got into clinical pharmacology in the 1960s because it was seen as important to medical education and to medical practice as a bridging discipline. And the idea of the bridging discipline was very prominent. Not just clinical pharmacology, but clinical biochemistry, clinical immunology, clinical epidemiology, and then increasingly infectious disease and vaccinology, and endocrinology, which of course in some ways had always been a bridging discipline. But in 2023, the field has changed. You just have to look again at the program for this meeting. Look at the keynote speeches. Look at the plenary sessions. They are almost all concerned with molecular biology, with clinical oncology, with immunology, with medical genetic knowledge writ large and translated into therapeutic decision-making. In a way, pharmacotherapy itself has become the bridging discipline. I really sympathize with the organizers of this meeting who set out to create some kind of unified meeting around pharmacology. But pharmacology touches on every discipline in human biology and in human medicine. So in a sense, it is the bridging discipline. Clinical and translational research, which we'll hear more about and have heard about all week. Artificial intelligence. Many plenary speakers have talked about the importance of biodata banks and how we can use those to draw conclusions about the optimal treatment of disease. Machine learning, quantum computing, the list goes on. But clearly, the bridging disciplines today are not the same as they were 50 years ago. And of course, that means that undergraduate education has to change. The future is most definitely not what it used to be. I'm not going to talk about specific therapeutic innovations, but obviously the scientific underpinning has changed with the emphasis on molecular biology, and that has spins off into new therapies and new ways of looking at therapies and new ways of teaching about them. Times have changed from Rembrandt's era, but unfortunately, I think in many pharmacology departments in my country, and I expect in yours, people are still using very outdated methods to study very outdated therapeutic concepts. When we're looking now at hugely complicated molecules, we've gone from small molecule pharmacology, small molecule therapy, to complex molecule therapy, and we need new ways of using our knowledge so that we can tailor the therapy to particular patients, and we can tailor our investigational methods to the new therapeutic modalities. All of this, of course, has led to a paradigm shift in how we make decisions about therapy. What kind of evidence do we need to make therapeutic decisions? It's no longer black and white as it was 100 years ago. We've taken for the last 50 years at least randomized controlled trials as being the gold standard for deciding whether a therapy was going to be safe and effective. I think today we have to admit that RCTs are of limited applicability. They cannot easily be transposed to a broader population after being studied in a highly academic setting, often in a very small segment of the population. We have to learn how to use pragmatic real-world studies. We, in many therapies, not all, but the majority of therapies today, we have to have some proof of the ability of the new entity to ameliorate or offset molecular abnormalities that we now understand. And this is a topic for another day, but others have mentioned during the week the enormous cost of these new therapies. We can't, as pharmacologists or clinical pharmacologists, just accept new therapies as being essential without taking into consideration the enormous cost of them. I mean, I sit on a committee that reviews all new drug therapies in Canada to determine whether they'll be reimbursed by private insurance companies. It's not, we meet once a month. We consider half a dozen products usually. We haven't had a month in years that didn't have at least one product that costs $1 million a year, and some as high as $3 million. So we have to take this into account as we look at new therapies. And of course, the last point I think is self-evident, that we have to continuously acknowledge the importance of safety and see that as equal to efficacy. This was an important thought process 20 years ago. It was considered that we were getting stuck because of our progress in basic biomedical research. We were confronted every day with enormous breakthroughs in basic knowledge, but we had real trouble moving from that into clinical science, clinical knowledge, and even more trouble moving from there into clinical practice and healthcare decision-making. And I think this may have been the flavor of the month in the 1990s, but it's still true in 2023. And I think part of what we're talking about today is how we can design a health professional training curriculum that will help people to engage in appropriate clinical decision-making. Meanwhile, the clinical research environment has also changed dramatically. We understand more and more about the complexity of health determinants. We understand, as I've already said, how important it is to make use of the data science that we have, make use of big data to guide us to potential therapeutic choices. We need new research methods that will actually address system complexity, not oversimplify it. We need adaptive methods. We have to get beyond randomized controlled trials, in most conditions at least. And for my former McMaster colleagues, I have to acknowledge evidence-based medicine and the importance of that discipline evolving toward more precise guidance that takes into account these pharmacogenomic insights that we've gained and that are now represented in the labeling of so many drugs. And I have to say, when all is at the end of the day, management requires measurement. We have to be better at measuring the outcomes from our therapeutic decisions. I think Florence Nightingale said this during the Crimean War, that if you can't measure it, you can't manage it. And it's absolutely true. What I'm really advocating for, I hope it's self-evident, is better understanding of critical appraisal. Recognition that this is essential to modern practice in any health profession. You've got to know how to read the medical literature, how to interpret it, how to determine what's valid and what isn't valid. And this Institute of Medicine report is about 10 years old now, but it's good, and it underscores the importance of understanding what works and what doesn't work, and what works in which patient, and what makes patients different, one from another. Well, I mentioned that I'm on a committee that looks at all new therapeutic products and decides whether they'll be reimbursed by private insurers in Canada. And I thought I might illustrate the difficulty of this activity just by showing you a random sample of, as I said, we see about 6 new products a month. Here's 6 from the last 6 months, picked more or less at random. But I would suggest to you that most people trained in pharmacology in a conventional university environment during my lifetime, I would have a very hard time understanding the place in therapy of most of these drugs. Ozanimod, sphingosine 1-phosphate modulator, Assesment, I can barely pronounce the names, Assesment, a tyrosine kinase inhibitor, tezepelumab, thymic stromal lymphoprotein blocker for asthma. I'll stop torturing you with my pronunciation, but Safnello, an interferon antagonist, Radicava, a free radical scavenger for amyotrophic lateral sclerosis, Camzyos, a cardiac myosin inhibitor. Believe me, this is 6 out of about 35 drugs that we've looked at in the last 6 months. There are another 20 that are exactly like this. There's a very small minority of drugs that would be understandable in conventional terms and would be subject to conventional therapeutic choices for treatment of very common diseases. So what's happened to to undergraduate health professional education in the last 50 years? Well, I don't think this has happened universally, and every country, every city, every university will be a little bit different, but I think there has been a shift from fact-based teaching to skill-based teaching. We've gone from strongly didactic programs to more problem-based teaching. We've gone from passive learning to experiential learning, experiential training. I think in the most progressive medical schools, most progressive universities, there's been an appropriate emphasis placed on teaching students resilient critical appraisal skills, as I've already mentioned. And this, if it's done properly, preserves their capacity for therapeutic versatility. This preserves their ability to continue to practice for 40 or even 50 years after they graduate. Without it, they're frozen in time. They will not be able to adapt or to practice in a competent fashion over a lifetime. And I guess I would synthesize this by saying that we've come to recognize that every practitioner needs to be trained as a clinician scientist. Not that they need to become clinician scientists, but they need to have the skills that clinician scientists have learned, and they need to be able to apply that to the burgeoning literature in health sciences. None of this is new wisdom. Poincaré, 1854. Science is built of facts the way a house is built of bricks, but an accumulation of facts is no more science than a pile of bricks is a house. Well, when I was in medical school, which was only 50 years ago, we were still being taught that you could build a medical practice on a set of facts that were inculcated during medical school training, and were going to be updated who knows how over the ensuing 50 years. I have to, Michael mentioned, I think, that I'm really a pediatric pharmacologist, so I have to digress just for a moment to remind you that one of the deficiencies in our healthcare professional education programs is our dealing with children, and this is particularly true in pharmacology or clinical pharmacology. We don't do a good job. We haven't done a good job of studying drugs in children, and we certainly don't do a good job of preparing graduates to practice pediatrics in pediatric therapeutics in the future. I'm sure most of you realize that 25% of the world's population are now children, and more than that, the vast majority of those children are living in lower and middle income countries, or maybe in upper middle income countries. They're not living in Western Europe or North America, where our therapeutic concerns are somewhat different. So this is just a plea that that those organizing undergraduate curricula take into account where the world's population is and what their needs may be. And this is part of the same argument. Africa today is about 1.2 billion people. By 2050, 2.4 billion people. That's where the growth in population is occurring. And of course, the growth in population means that the populations are extremely young. So the needs of children in countries like Nigeria and Uganda, where 50% of the population are under the age of 14, are enormous. And we simply don't have the information to design a curriculum that would allow us to deal with that. So most of you, I hope, in the room are familiar with the Flexner Report on Medical Education in the early 1900s, looked at all the medical schools in North America. If Flexner were to return this year and look at how we're doing in health professional programs in 2023, I think he might ask these questions legitimately. Do graduates possess the requisite skills for a lifetime of successful practice? Not in any school that I'm aware of. Have they gained the capacity to critically appraise new scientific findings? I've given you my view on that. Will they be able to master increasingly precision-targeted treatments? Are they familiar with the principles of outcomes research and the assessment of value added? Will they be able to deal with the economic questions that are important in every country in the world? And are they prepared to work as part of a multidisciplinary team? Very difficult challenges, but I'm afraid most health professional programs that I'm aware of are distinctly limited in this regard. So I'll end with this. There's nothing new under the sun. Goethe said this in the 19th century, and I'll spare you my German, but we know accurately only when we know little. With knowledge, doubt increases. I guess all I'm suggesting is that those who design health professional training curricula should take into account the fact that there's very little that we know with certainty, that we should have legitimate doubt, and we should teach our students how to think, how to judge, how to make appropriate choices over the next 50 years of their professional lives. Thank you very much.
Yeah, my name is Roland Seifert from Hanover Medical School. Thank you very much for this outstanding presentation. I'm one of the pharmacology professors in Germany who's kind of leading also an initiative regarding the question, how do we teach pharmacology to the medical students? And in our country, we fully agree with you, what you have presented. So I'm very glad that independently we came to the same conclusion. And the major challenge is, of course, how do we deal with these many drugs that we have these days? And what we have done, and this was really a fun initiative, that across all medical specialities, we agreed upon a curriculum of 300 drugs that the medical students should learn to different extents, of course, and we also implemented to cope with a high number of drugs that you can barely pronounce these days. To integrate also the INN stems into the curriculum, which has the advantage that these days you can cope better with all the delivery problems that we have globally with drugs. And so we are limiting ourselves, and many of the aspects that you mentioned that are nice to have, we simply cannot integrate it regarding the precision medicine. But our goal is also to have a practitioner in first place as a goal of education.
Well, you know, of course, I agree with you. You have my sympathy. Yeah. But I do think that even 300 drugs is far too many. When I started out as a professor of pharmacology in the 1970s, we had the idea at the University of Toronto that we we would focus on 20 drugs.
Yeah.
20 drugs that required mastery.
Yeah, we are actually boiling it also down to probably 50 to 100, where you should have a little bit more detailed knowledge. And we also integrate, this is very important, I think, the aspect of pharmacoeconomy, so that we critically discuss the inappropriate prices of many of these oncology drugs that are not really related to their effectiveness.
Yeah.
So we train the students in this regard.
No, I think what you're saying is correct. And I'm not suggesting that people should graduate from their undergraduate years with no factual knowledge at all. I mean, clearly they have to have some understanding of molecular biology. They have to have some understanding of chemistry, basic pharmaceutical sciences. But we need to be giving them the skills that they can then apply to the whole pharmacopoeia. And the pharmacopoeia is vast. I'm not sure how many, I think there's probably 7,000 drugs in the US pharmacopoeia now. There's no way we're going to graduate students with factual knowledge of that many products. But if they graduate with skills that will allow them to read the literature and make appropriate decisions, then we will have made a big jump forward. Thank you.
Just one over here. I'm over on this side to your right.
Hi.
Thank you, Professor. That was a fantastic journey through the history, and I'm reminded that William Murrell in 1896 wrote a letter to the editor of Lancet in which he lamented the proposal to remove pharmacology from the medicine exams. He was at the University of Edinburgh. And in that very, very eloquent letter, he mentioned that those physicians who relied on always looking things up were of no use in an emergency department when someone came in with a toxidrome and they couldn't work it out for themselves. And he said, any man, and now we mean beyond men, but any man who doesn't know his pharmacology is little better than a quack. So I wonder if you would mind commenting on the shift between a letter like that in 1896 and where you see medicine going now.
Yes. I'm not sure I can say anything very sensible about it, except I would have said the same thing even in 1896, that it was premature to get rid of pharmacology. I think today, of course, as I've been saying, we probably should downplay the traditional teaching of pharmacology organized as it was and emphasize instead the need to teach practitioners how to think. And I'm not averse to somebody having a peripheral brain that they consult in the emergency department to get the right dose of the right drug. But I believe in order to have some inkling of what the right drug may be, they have to know how to read the medical literature, which is changing on a daily basis. The volume of information is just enormous. So, but there's no way of sorting through it in some kind of mechanical way unless you have an understanding of the interplay between drugs and various biological processes, including the presence of genetic abnormalities.
Thank you very much.
Here, I'll give you one last quote, another Canadian quote from the University of Toronto. If medicine can stretch sufficiently to be both an advanced science and a healing art, it will successfully fulfill its ancient aspirations in unprecedented ways. So I think we are on the threshold of fulfilling our ancient aspirations in unprecedented ways. Thank you.
Thank you. And just a comment in deference to our German friends. There's actually Carl Clausewitz, whose book Vom Krieg has been misquoted more than any book except possibly the Bible. did make a really interesting comment about the purpose of education, because he was at one point in charge of the Prussian Military Academy. And he said, the goal of education is not to impart facts, it's to teach people to think. And I think that applies equally to our medical students as it did to the cadets in Brandenburg, Prussia, 150 years ago. Our next speaker is, I'm delighted to introduce our next speaker, Dr. Lionel Lewis, I've known for many years. Dr. Lewis qualified at Wales, then trained at Geisel, then went to Hopkins where he did clinical pharmacology, and then was recruited to Dartmouth where contrary to much experience in the US system, he's remained to this day. And he's a professor at Dartmouth. He's a very active researcher in the area of oncology. He runs a phase 1 unit. But germane to our session today, he and Dan Nuremberg have been very active in the area of teaching medical students. And unique to most American medical schools, they actually have a very robust fourth-year course in pharmacology and therapeutics. I'm really looking forward to hearing Dr. Lewis's experiences and how that course trots out.
Thank you, Mike. I'd like to thank Dr. Rieder for the introduction. I'd like to thank the organizers and appreciate everybody's stamina, and maybe caffeination is good for all of us at this point in time. So as Mike mentioned, what I want to talk to you about today, I've been fortunate enough to work with a guy called Dave Nuremberg, and he created initially, and we've carried on, a course that is focused on clinical pharmacology and rational therapeutics, but it's for fourth-year medical students in the US, which is the final year medical student. So I'm going to talk to you about that in some detail. So what I'm going to do as an outline is briefly give you a history and background to this course. We call it the CPRT course, Clinical Pharmacology Rational Therapeutics course. I want to spend some time detailing the content of that course so you can get a clear picture of how this course is operationalized and its content. And then I want to talk a little bit about how we do the assessments of the course, because I think we've done some unique things here. And then finally wrap up with some summary comments. So the course at Dartmouth is a required course for graduation. So students have to perform and they have to go through the course successfully. And it was initiated early in the 1980s, but the first course was offered in 1984. At that time, Dave Nuremberg was the sole clinical pharmacologist at Dartmouth. I joined him in 1993, and we've been teaching this course as co-directors since then. What I would say is that the course has morphed over those 40-odd years considerably. We started off with a course that was often about 6 weeks in time. We had about 60 hours of teaching, but with the constraints of and advances in the medical curricula, we're now down to about 32 hours. This has also been driven by feedback from the students, occurrences such as the COVID, the pandemic, and also the evolution of teaching materials and teaching media. Our goal is still to maximize the prescribing competency of our students using the final integration of basic and clinical pharmacology. As Dr. MacLeod highlighted very nicely, yes, indeed, we cannot let our graduates go into the practice of medicine in hospitals or their early years without becoming true clinical scientists in pharmacology, where they integrate their basic knowledge with the clinical therapeutics. I believe, from my last time I looked around in the US medical schools, there's about 150 US medical schools and about 20 DO schools. There are only 2 or 3 other schools that offer a course that's anything similar to this. So we're actually fortunate and unique. So our course is based on a 4-week period right now in March of the final year. Why is this good timing? Well, our graduates are moving on into their residency internships equivalent to foundational years in the UK in late May or early June. So they're right at the peak of their training from their clinical clerkships. And essentially, the course is taught and directed by 2 of us, myself and Dave Nuremberg, who I have to acknowledge at this point, which I know is unusual for a presentation to acknowledge the co-partners, but Dave is clearly my colleague, my collaborator, and my sort of go-to person and discussant around this course. So let's delve into a little bit more detail into the course content. So we have presentations which last about 55 minutes. We're not allowed to go to 60 minutes because everybody's attention span is not that long. During that presentation, it's a case-based presentation where we use the clinical cases to highlight the teaching point. And then also, we often have a multiple choice question attached to that because the students are very averse to having exams at the end of our course. Our slides are posted on our electronic board, and of course the lectures are recorded. And many of you will know that the students play these recordings back at 1.5 or 2 times speed, right? So they don't take the time to actually listen to the whole thing. The course is broken up into several components, and I've given you some indication of roughly what that, shall I say, proportional components are. What we have is, we have the core topics, which are about 18 hours of a 32-hour course. We have emergency therapeutics for about 5 hours. We have special populations or specialty therapeutics for about 4 hours. What I call clinical pharmacology conferences, the equivalent of clinico-pathological conferences for those who do pathology. And we also have a prescribing quiz. And one of the things we've instituted over the last 2 or 3 years is a work that the students are requested to do called entrustable professional activities. And I'm going to delve into that in a bit more detail. And then we also have 2 different course assessments. So let's deal with the core topics. And many of you will be familiar with these topics. And what we've done is we've taken really trying to focus on the common aspects of clinical therapeutics. The course introduction gives the outline of the course, the expectations of the course, but at the same time, we insist that the students are aware of what we want them to learn. We agree that they only attend 80%, and they vouch for that. We don't take attendance. We introduce them to our e-drug databases so that they can look up the drug monographs if they don't know much about it. And then importantly, that software allows them to do a drug-drug interaction search as well. And that is vital these days because of the number of drugs we have. And I don't know how many of you see patients with polypharmacy these days, but we're seeing patients in our clinic with 20 to 25 drugs on board. And that's, if you look in the ICU, it's an average about 20 patients. So we also introduce them to our electronic medical record. Now, the EMR is okay for electronic prescribing if you can get access to it. But unfortunately, our EPIC doesn't allow our students access to write in the medical record. They can only read. So we have to substitute that with some exercises. Then we go on to some classical areas in clinical pharmacology and therapeutics. We think of the 2 organs that clear drugs from the body, and we look at the dysfunction of those organs and how that affects PK and PD. In addition to that, we turn part of the lecture back and talk about drugs that are toxic to those organs. So we have 2 parts to each of those lectures. We have to talk about drug regulations and prescribing, and we also focus on prescriptions because one of our entrustable professional activities is about actually writing a prescription. We have things about ADEs and ADRs. We have drug-drug interactions. Management of pain is important these days. With the opioid epidemic, the transition and guidances around use of opioids for chronic pain or lack of use for opioids, or shall I say optimization of use for opioids, both in acute pain and chronic pain. And as importantly is to use multimodal types of therapies for treatment of post-operative medications. Then we have a session on clinical PK applications, remembering that early in this course, we had more detailed pharmacokinetic information, and I could see the students' eyes rolling over and going to sleep. So we try to make the PK applications appropriate to cases. At the same time, we use them to impress on the students the importance of thinking about how that impacts dose and schedule. And then we have drugs in the prescribing in the elderly, which is very important. And that really officially looks at, or shall I say, formally emphasizes things about deprescribing and prescribing carefully with the knowledge of how the impact of PK and PD in the elderly is different. The other parts of the core topics, it's important to recognize substance abuse and toxidromes, which was mentioned earlier, drug allergies, steroids, genetics in prescribing. We have 2 sessions on this. We have one that talks about some of the commonly used drugs with recommendations by the FDA to modify dosing. And we also have a session where we look at how will future prescribing in institutions change. For example, where you get a credit card with your pharmacogenomics on or other genomics, and you present it to your practitioner and say, here's my genes, what drugs can I take and not take? Have you got the right dose, doctor? So we have 2 sessions on that. And we have a session on interaction between drugs and diet and herbals. The important things here are things like emphasizing the issues around grapefruit juice, emphasizing the issues around St. John's wort, but also thinking about other dietary issues, and certainly modifying and thinking about asking about those things when you take a drug history. We talk about drug development and the FDA's role. We talk about generics and biosimilars. And this gets a little bit to the comment that was brought up about the financial toxicity that we're feeling as a prescribing practitioners these days, where the range of costs for oncology drugs is somewhere between $60,000 a year to anything up to $600,000 a year. Update on anticoagulants and antiplatelet agents, talking about those new oral anticoagulants and how you can potentially reverse them. And then molecularly targeted therapies. Here we talk a little bit about the oral medications in oncology, but this is focused a discussion on two aspects. There's about 130, I believe, approved monoclonal antibodies that can be prescribed today, ranging from inflammatory bowel disease, ranging from psoriasis, ranging through multiple sclerosis that we heard about in the symposia, and also thinking about oncology. So they get a flavor of the common agents that are used, but they can't know all of them. The issue is to recognize the suffix here on the generic name and guide them to where to look at. So the emergency therapeutics that we deal with, this is one of the most well-received components of the course when the students do their evaluation. We talk about overdose because it's important. We talk about management of shock. We have a session on hypertension, SVT, and hypercalcemia, and myocardial infarction, cardiac pulmonary edema, and AFib, and antibiotic emergencies for threatening life infections. Dave and I can't cover all of this. We're reasonably broad in our internal medicine knowledge, but we turn sometimes to our specialists. We often have a pediatrician come in and give us a guidance on case-based prescribing in children. We have a diabetologist give us the talk on ambulatory treatment of diabetes mellitus, because that has changed so radically over the past 5 years. And then we have a psychiatrist talk about therapeutics of psychiatry emergencies, and somebody from an OBGYN department talk about pregnancy and breastfeeding. Then we go on, and all of these are integrated into the course, to talk about what I call clinical pharmacological conferences. This is examples of actually cases that my colleague and I have usually seen on the wards somewhere at our institution. And one of the ones we do is when cancer chemotherapy infusion pumps go wrong. The infusion pump in this case ran over 2 hours instead of 48 hours. The patient got an overdose of 5-fluorouracil. And we talk about the toxicities that we're seeing, the mucositis, the hematological suppression that's seen, and then we talk about the potential reversal agent triacetyl urine that's just become available and change the number of fatalities that occur with this particular problem. And we talk about the issue of how does the system respond to this? What do we need to do to stop this happening again? What are the legal implications of this as well? The next case we do is an acute cerebellar ataxia that leads to a lethal exposure. And this was unfortunately a very sad case that we were both involved in, where one of our faculty members in chemistry was studying dimethyl mercury, which is an organic mercury, highly soluble. Unfortunately, the individual dropped a couple of drops of this on her gloved hands, and it was absorbed through those gloves into the body and subsequently into different organs, particularly the brain. And she developed an acute cerebellar ataxia syndrome and subsequently progressed to death. And if you look, this was reported in the New England Journal several years ago. And this particular slide shows her cerebellum on the left, which you can see is atrophic, compared to a normal cerebellum on the right. The other cases we use is a case of post-op fever, delayed conscious, or shall I say, regaining of consciousness post-operatively, and what I call azourine. And the key to this case was this physical sign. Blue-green urine was the real odd thing. So this gives us the opportunity to search what can cause blue-green urine besides Viagra, various other pills, certain bile acids. But it turns out that there's one or an intraoperative medication that can do this, and it's methylene blue. And the issue here was the patient was on an SSRI, and methylene blue can cause, in conjunction with SSRIs, a serotonin syndrome. So we were able to weave in a lot of information, not about searching the literature, but also talk about serotonin syndrome rather than malignant hypothermia or NMS. And the issue was it was a serotonin syndrome related to the treatment with methylene blue that's used as a vasopressor agent. And then we got another case, which I saw on the ward with Dave, about delayed CNS toxicity is what the Welsh call toxic alcohols, because they're more toxic than ethyl alcohol, ethanol. These are methanol and ethylene glycol. And we had a couple of patients up in Dartmouth who developed a delayed Parkinsonian syndrome, as evidenced by this MRI, where you can see on the left-hand side of the middle of the B phase and the E phase, you can see the left putaminal hemorrhages. But I got the opportunity here to revise with the students how the people taking these toxic ingestions actually develop acidemia or whatever the complications are, and subsequently with ethylene glycol renal failure, or in this case, a delayed CNS effects. And also think about treating them with fameprazole and also managing these cases as well with anti-Parkinsonian treatment. So we use these cases to highlight certain cases we've seen that bring points that are hopefully not uncommon. So we also have one session on a prescribing assessment, which is in a way mirroring to some extent what Simon Maxwell has led in the UK. It's not as formal or as nationalized as Simon's safety prescribing assessment, but we base it on the same components. And we used, because our students, and maybe many students throughout the medical training schools, are really reticent to be put on the spot and asked to a question and answer. They feel as if they're being picked upon. So we use an electronic poll vote to give the correct answers to these questions. And I'll just give you an example of one of these that I took from our listing, which is a gentleman who had collapse, was in the cardiology ward, and he was currently being monitored, has another collapse the following morning, develops torsade de pointes that there was some discussion on today, and then we asked the students to select which most drugs should they discontinue. It gives us the opportunity to talk about drugs that cause torsade de pointes and how you treat it as well. So, and we have about 30 questions that we go through in a session, and we do it in a sort of in a non-punitive way, but in a learning way to learn more about certain scenarios. And then we come to this thing that I've called entrustable professional activities. These are done outside of the class. They're done on the student's own time. And we ask them to submit written work, which is unusual these days, but they can type it up and send it in. The first is a complete prescription for outpatient prescription, ambulatory prescription for a pediatric patient. The second is to manage a complex case of drug-drug interactions. And the third is to write a complete set of orders for an acute medical admission. It takes quite a bit of time, I have to admit, because we review all these pieces of work and critique them and feed back to the student, and we'll decide whether they are of an acceptable level to be passable or not. About 10 to 15% of the students with these types of exercises need to redo their exercise because the feedback they get is saying this isn't quite good enough. So the first one is a pediatric patient with a localized infection following a cat bite. We give them much more information than this. We give them the child's age, the weight, the prior history, any allergies, etc. And then we ask them to fill in the prescription. And this may seem archaic, but what I would advocate here is it's actually making them think about the elements that are required for a good prescribing process. So you have the name, the address, the date of birth, the age. You need the specific drug, the dose in milligrams per unit dosing, the ratio related to weight, the formulation, which is important, the total dose with 75 mils in a bottle and 5 mil spoons to administer to the child. Then the labeling that you want the pharmacist to put on it, take by two 5 mil teaspoons twice a day, take once in the morning, once at night, call a number if a problem, no refills, the prescribing person and the consulting attending, and a telephone number to ring you back. Now this might be totally, taken over by electronic prescribing, but I can tell you that still in New Hampshire, we still have to fax some of these prescriptions into some of the outlying pharmacies because we are a pretty rural state. And the students like it because they get individual feedback as to whether they've actually done this correctly or not. We also go over it in class, just in case some of them still haven't got it. The second EPA is somewhat more testing, I think. The second one might take about 30 to 45 minutes. And I've given you the summary of the patient here. Is a patient who's quite elderly in their 60s with hypertension, a mechanical valve replacement, coronary artery disease with stents, has asthma, anxiety, depression, gastroesophageal reflux, and is on a whole host of medications for those chronic comorbidities as well as warfarin, who presents in the ER or the casualty department and with an atrial fib or palpitations and atrial fibrillation at about 140 and a swollen left calf that's suspicious and proven to be a DVT. They have a set of labs there that talks about the renal function, the hepatic function, the hematological profile. But importantly, they have the INR, the subtherapeutic. And then we explore with the patient that they've actually been taking St. John's wort recently, and many of you are aware of the drug-drug interaction here, where St. John's wort is one of the most potent inducers because of the hyperricin component through the PXR receptor. This is just to show you, I don't expect you to read this, and the intention here is to show you the sort of information the student gets beyond that summary. The important thing is we ask them to think about the drugs the patient's on, how they're going to change them, and what they might need to introduce to manage the patient's current undercoagulation, DVT, and the fact that the patient has rapid atrial fibrillation. And this is the sort of response that we get. And again, I'm sorry this is so small, but there was no other way to deal with it. On the left-hand side, we have the chronic problem. In the middle column, we have the current drug therapy. And on the right-hand side, we get the students to write what they would change or not change. And as you can see here, one of us critiqued this particular student. And in fact, there were several problems. They did not think about modifying the dual antiplatelet therapy. They did continue sucralfate that can inhibit or reduce warfarin bioavailability. They still continued citalopram and buspirone. They got rid of the St. John's wort. That's good. Some of them wanted to discontinue an agent that would slow the atrial fibrillation. But importantly, this individual wanted to give usual heparinization rather than a bridge heparinization with low molecular weight heparin to bridge the person over while the warfarin became into the therapeutic range for somebody with a mitral valve replacement. This individual had to redo this. This is just an example, one that didn't pass the Lewis test, okay? Then the third EPA is even a bit more extensive. This EPA probably takes about an hour. And again, I'm going to give you a summary of the case so that you get a feel for what we're asking them, show you what the whole information they get is, and then talk a little bit about what the response we're expecting. So there was an acute admission of a patient with cystic fibrosis who has an acute flare of their cystic fibrosis with bronchopneumonia. We give them the clinical assessment of the patient with saturations, vital signs, wheezing, bronchospasm, et cetera, and the clinical status. And they have a set of labs that look at the LFTs, the hemoglobin, the white count, the appropriate renal function, and also their sputum sent off for microbiology assessment. Then we ask them to write a full set of orders and focus on new medications they may need to institute, or new medications they may need to institute, or medications they may need to discontinue. And this is the sort of information they get, again, around a patient with a flare of bronchopneumonia and cystic fibrosis. The key here is to think about the antibiotic therapy, and we actually recommend to them they go to up-to-date or a very up-to, or shall I say, a guidance from an accepted, knowledgeable electronic database of medical practice, which, as Dr. MacLeod pointed out, is changing most days. But this is an open book, so they can go to the literature and figure out what it says they should do. And then we ask them to write a full list of orders that defines the attending, the resident, is the condition of the patient stable or critical, what vitals the patient needs, what allergies, what activities they can do on the ward, what are the nursing orders, how often do they need to check the vitals, what should they call the resident for, do they need to be constrained as regards their activity of walking around the ward? Do they need nursing orders for protective respiratory potential transmission? We also talk about peak flow rates, etc. Diet is important in somebody with CF. We talk about labs that they need to repeat. What fluids, do they need fluids right now or not? Special testing might be a peak flow meter or an FEV1 if they can do it. And then they focus on the medications that the patient is on that may need to be discontinued, but they focus on things like the antibiotic therapies that may be initially empiric, and need adjustment because of the GFR that's increased in patients with CF. And they also need to think about treating the bronchospasm that the patient has. And then they might call in some consults, a dietary consult or a pulmonology consult. And again, I would say that roughly 15% of the class do a suboptimal job on this, and they have to redo it again. And then we actually reinforce it with the best. We take a session where the other thing we do to make the case is the sputum bacteriology comes back and shows the sensitivities. And the sensitivities here would argue that you might want to change the therapy from PIP to Tobra to meropenem and Tobra because of the sensitivities that come back. And that's what we're asking them to think about. But we also go back and do the whole testing of, we show some of the best examples which are anonymized from the class as examples of how some people can do. So how do we assess this course? And we've taken an approach that, again, I think is quite unusual. We have actually constructed our own questionnaire, which is anonymized, where we really ask the students at the beginning of the course and then at the end of the course in an anonymized, they don't have to sign their names to it because they really get upset about that sometimes. How many times have they done these EPA activities, written a prescription, derived a management plan for somebody on a number of drugs where there are drug-drug interactions potentially causing the admission, or the admission orders? And we found that when we asked those questions, the number of times they've done it during their tenure as a medical student and at the end of their training was anything from 1 to 2 was the best. Often, many of them was 0. They'd never done this before. The other thing we wanted to explore was there an improvement in how they felt about doing these entrustable professional activities at the end of the course? And this is, again, the student questionnaire, which focuses on how often they've done it, how often they've prescribed, how often they've done a drug-drug interaction, how often have they written orders. But I'd focus on how confident you are after you've done the course. And we were able to do some statistics over the last couple of years. And this is the statistics from the most recent course, where we had about 70 students, 62 of whom did the prescription on day 1, and only 31 of them turned up to do the prescription in the end. The reason for that is the end of the course was like 2 days after match day, which is the big day when they find out where they're going to do their initial clinical training as fully fledged junior doctors. And you can see that there's a significant improvement in the medians from the first day to the end for the drug interaction, the admission orders, and the prescribing. And we did a Kruskal-Wallis analysis of various initially that showed there was a highly significant difference between these groups. And then we went on and did a post hoc comparison of these, and again we found they were highly significant. So we felt that we were really impacting their ability to do these entrustable professional activities. So there is also an institutional course assessment, again anonymized. I would say in the Welsh terms, it's fairly typical. You know, what was the best part of the course? What was the worst part of the course? Did Dr. Lewis talk in Welsh too much? What was the score for individual presentations on a basis from 0 to 5? How many noughts do you get? How many 5s do you get? Was the length of the course appropriate? Was the timing of the course during this period a good time for you? Which I think it is, just because they're going to become the equivalent of foundational doctors in about 2 months. And the content improvements they'd suggested. We get a summary feedback usually several months later, some of which is sanitized because occasionally there are some unprofessional comments in there, and we get course reviewed by the Medical Education Committee every 3 years. So what are we thinking and where are we going in the next couple of years? Because this course has evolved over the last 35 years and has had to evolve. So the first thing we thought about was, you know, we used to have an MCQ exam at the end of the course, and the students got really upset, and we had to move from a graded course evaluation to a pass-fail situation. But we think we'll go back and do a pre-course medical therapeutics MCQ. We'll probably do it using the polling system, and they'll see how they do. And then we want to do this, not the same questions, but different questions on the same topics at the end of the course and see how they do. I also want to bring in, because in developmental drug development, it's sort of foreign to them. Most students have never seen a phase 1 patient. whether it's a healthy volunteer or something that I work in, which is phase 1 oncology. And I had a couple of patients I talked to about this in my clinic, and they were more than happy to say, yeah, I'll come along and have 5 or 10 minutes discussion with your students. I'd have to be careful about the HIPAA the regulations here, but I think we can get round that by common sense. And then the other thing we're pushing is to get our medical school administration to actually provide a prescribing competency in the transcript for our students, because they really do go through a process of prescribing competency at the end of the course. So in summary then, I think we have a pretty unique course. I'm fortunate enough to be part of it. Our goal is to maximize our students' prescribing competency. It's very similar to what the UK system is trying to do to ensure that their foundational doctors are doing the same thing. The interesting thing to me is this is clinical pharmacology, right is where it should be from medical education. The course was built by Dave and myself, and we primarily teach about 94% of these topics. And we're looking forward to the students get rational training in therapeutics, and they actually do get a prescribing assessment, although it's not sort of a formative one, and they get prescribing competency. So at that point, I thought I'd introduce a little bit of Celtic diversity to this presentation and say, diolch am eich sylw, cwestiynwch os gwelwch yn dda, and that's for only the 300,000 people who understand it, and for the 8 billion of you who don't. Thank you for your attention. Questions, if you please. Thank you very much indeed.
Hi, Kelly Charles from Sydney. We have a similar program in Sydney, so it'd be lovely to try and catch up maybe afterwards and share some cases to see how our students do internationally or globally. Have you ever thought of trialling the PSA in your cohorts in the US to see how competent or equivalent competency they are? I know in Canada they've tried it, and we've been doing it in Australia and New Zealand.
Yeah, we sort of do it in that prescribing quiz that we do, and we use that as a sort of non-formative assessment, and they can see how they do as feedback. We certainly wouldn't mind doing it, and I think the issue is that the students at this point, because they literally are in the process of getting through to finding out where they're going, is their attention span and their like for any sort of exam or any sort of test is very, very low, and they rebel a lot, and the feedback you get usually is, why are we being tested again? I passed my step 2, I'm just about to go into the hospital, why are you testing me about this? So I think it's a great thing to do, and we try to mimic it with that prescribing thing that we do. But sure, thanks.
Hello, hi.
Yep.
Here.
Got it.
Yeah, so we at the American University of Beirut, Lebanon, have been giving a clinical pharmacology course for the past 15 years. And I'd like to share with you some of our feedback that is very similar to yours. So one, we canceled the multiple choice questions. Now it's a pass-fail course. We initially started it in Med 4, but then moved it to Medicine 3 because our student wanted this competency early on. I don't know if in your case it's the same. They didn't want it to be at the end. They wanted it in the beginning. And one question also concerning the EPAs, we have one on prescription writing and one a case similar to yours. But we're struggling with 2 things. One is the correction. I don't know if you are actually correcting every single one. We have 100 students. I don't know how many you have. And the second one, specifically the case, students are unfortunately not doing it individually. So this is why I actually canceled it.
That's interesting.
I don't know what is your take on that.
Great. I mean, thank you so much for your comments. Number one, we're constrained where we can put our course by the curriculum committee, and the 3rd year and the 4th year are really very filled with clinical clerkships. So we can't put it anywhere else because our body of students are actually quite spread out across the tri-state area, and some of them are even spread into the West Coast. So it's very difficult to get the whole class together. Our class varies. This year we had about 75 students. And next year I know we've got 101. And that pushes both of us to a lot of work during that March period. We do ask the students to do these on their own rather than in teams. Whether they still adhere to that request, I'm not sure. So I take your point, and yeah, I agree with you. The timing, I think, though, for our students is right at the right point, because it's right when they're going in to become junior doctors, foundational physicians. Thank you.
Thanks very much. Michael Curry from Brighton, UK. So following on from that question that just came through, how much practical prescribing do your students do leading up to their fourth year? How much practical prescribing? I've got a second question as well.
So can I answer that one first?
Yeah, of course.
So the bottom line is when we do that questionnaire, there's a significant proportion of them who are 0 or once that they've actually written a prescription or generated a prescription, whether it's electronic or otherwise.
Okay. And the other thing is, you know how there's plenty of data to suggest that graduating medical students are not confident. They're terrified of prescribing. One of the clinical skills that they're most terrified of is prescribing. Do you think as medical educators we place too much of an emphasis on what can go wrong, prescribing errors, rather than a lot of the data you've presented, quite a lot of positivity, the rewards of how it can go well. If you think about an operation, we don't start with the post-operative complications. We start with how it should be done perfectly well. So do you think as educators we're kind of falling foul of that?
I think that's a great point, and I certainly recall from the cases that are given within the lectures, they're often, shall I say, as you suggest, how things do go wrong. But I think there's a lot of learning from that, because I don't know about your memories, but the things that stick in my brain in my career, which spans quite a lot of time because I'm a grey hair, it's what went wrong I remember best, and that's whether it's therapeutics or otherwise. But I think you need to balance it, and I agree with you. We need the positive aspects with those negative issues as well. So I think a balance is the way forward.
Thanks.
Thanks.
Thanks very much.
Thanks.
Great talk. I think that raises the issue of how many you prescribing is an interesting one, because I ran our undergrad therapy at University of Ontario for 25 years. And I would say 10 years ago, our students were reasonably competent, because during their clerkship, they would write the average of 300 prescriptions. However, when you switched to the electronic medical record, that went from 300 to about 20, maybe. And sometimes, like Lionel says, 0. I think that's a problem. And on that topic, I'm pleased to introduce our next speaker, which is Dr. Naomi Burns, who's at the Brighton Sussex Medical School. She's one of Michael Corey's fellows in clinical pharmacology, interest in medical education. She's going to talk to us about electronic prescribing. Thank you.
Okay, thank you very much. Yes, I'm a pharmacist by background. I work at University Hospital Sussex, and part-time I'm also a clinical fellow at Brighton and Sussex Medical School. And I'm here to talk about the introduction of electronic prescribing assessments to newly qualified doctors. So prescribing is obviously a key role for junior doctors, and in pretty much most UK hospitals this is commonly done on paper. And as a result of that, local training and assessment relies on these paper methods. So commonly paper drug charts, of which there are many types and designs depending upon where one works. However, back in 2020, the UK government said that digital prescribing was to be expected across the whole of the NHS next year, due to a £16 million fund to improve patient safety. And this would obviously therefore negate the need for paper. So back in 2011 now, Kent, Surrey and Sussex Deanery, they established a group, predominantly of pharmacists, to develop a regional prescribing assessment. And this is us, Kent, Surrey and Sussex. We're here on the southeast coast of England. And this assessment was really to fill the gap prior to the arrival of the prescribing skills assessment, as it was called then, that was being introduced by the BPS. So the aim of this assessment was really to identify individual junior doctors' training needs, confirm their acquisition of prescribing competencies, and get them familiar with their hospital's prescribing standards. So this was undertaken across a large number of hospitals in the region during the junior doctors' induction period, which is generally their first week on arrival. And this continues to this day. So it's taken each year by up to about 800 newly graduated trainees, Foundation 1 year doctors. But much of this is utilised, still done on paper drug charts and using paper guidelines. It consists of 5 different scenarios, focusing on high-risk medicines. They have to calculate a loading dose and a rate, amongst other things. And being on paper, it tests for their legibility as well as their prescribing skills. It's 75 minutes, and there's a marking guide that's provided with criteria for standardisation purposes and allows one to give consistent feedback. There's a marking spreadsheet, and then guidance is given to enable sort of support for poor performers, signposting them to e-learning programs such as Script. Now, where I work in West Sussex, we introduced electronic prescribing several years ago now. And it was recognised that we were really going to have to move away from a paper assessment to an electronic prescribing assessment. And so in 2016, we got together a group of IT, our electronic prescribing team, myself, medical education, to really consider what this was going to entail, what was this going to involve, what are the logistics of this. So how many computers were we going to need, how many licenses, right down to the number of sockets, where we were going to put all these computers, and how much time was this going to take in their induction programme. We also needed to create, obviously, an assessment and needed to adapt that on what was quite a well-established regional prescribing assessment. We decided fairly early on that we would keep the clinical decision support system on within the electronic prescribing system, because this would mimic real life. This is the system that they were going to be using literally within a few days. And so as a result of that, that did remove the need for some questions. And so therefore we decided to add some other aspects to the assessment instead. We tweaked the marking guide and the spreadsheet, and we piloted it on a handful of junior doctors to see how that worked. Was the timing appropriate? And then following that, we needed to create a number of patient templates on our electronic training system. So we've got about 300 of these. So we have about 60 junior doctors arrive each year. And because there's 4 scenarios, that comes up to well over 200 patient templates. So what I mean by that is that they put in the hospital number for their patient, and this pops up. And so very much like they'd expect to see when they saw a real patient, they're ready to prescribe for this individual and to following the scenario that's given to them. So each year we notify our junior doctors before they arrive as to what's involved, what's expected of them, and they get hands-on training on the prescribing system itself prior to the assessment. And the assessment, again, is very similar to the regional prescribing one in that it asks them to review and update the patient's allergy status, complete a thrombosis risk assessment, stop and start some high-risk drugs, to look at our antibiotic and anticoagulant guidelines to facilitate the questions, as well as prescribing a discharge prescription. We've got a comments section on the paper in which they can make some notes, some jottings down, some workings, some explanations, which is sometimes useful for us when we're coming to market to see where their understanding is, and really sort of sometimes try and differentiate between what their IT skills are and what their prescribing skills are. So this is an example of one of the questions which we'll probably revise this year, but it's simply asking them to prescribe some analgesia, to prescribe a maintenance dose of warfarin given the individual's INR, and to convert a liquid morphine product into a modified release product. So we follow the same process as the regional prescribing assessment that, as I said, is commonly done on paper. We mark it, we give group feedback and individual feedback, and where needed, we notify the ward pharmacists, educational and clinical supervisors for those that haven't performed as well as would be expected in order to give them some support. We ask for trainee feedback. And most of them think that the questions are about right. It's not asking them to do something that would not be expected of them as a junior doctor. And they find it quite useful as an exercise prior to going out on the wards a few days later to manage real patients. And think that it gives them a good understanding of the electronic prescribing system as well. So we analyse the results and the questions, and we do an annual review of those questions and how they've performed, and how each question is performed. We find that the results are fairly consistent each year. The number of serious errors made does vary from year to year, and maybe more individuals in one year make serious errors than another. What we know is that those that score poorly tend to make more serious errors. There's not those that have a good mark and make a number of serious errors. And the topics, not surprisingly, perhaps where they don't do quite so well, are those involving anticoagulants, insulin infusions, and even different inhaler devices. And sometimes it's also about understanding the nuances of electronic prescribing being a live system, so timing is really important. What we've also observed is that they ask a lot more questions on the task. So how do they do a certain task? It's not about a misunderstanding of the question or their prescribing knowledge. It's remind me how to do a certain task because I want to prescribe X, Y, or Z. We also find, I think, it probably takes a little bit less time to mark because of the improved legibility, and with the use of protocols, there's less variation in what they can do on paper. It does require good communication and collaboration with all parties to implement this, as well as the sort of significant resources and planning time. But what we're looking to do, what our next steps are really, to assess the data and determine if there's any correlation between the scores of the prescribing safety assessment and this regional prescribing assessment. And does this predict performance and whether individuals require support. So we're just at the very early stages of doing a pilot study with our data and using the GMC's UK Med repository of PSA information. So in conclusion, e-prescribing assessments, I think, are feasible, although there is a large range of e-prescribing systems within the UK. And with the introduction of electronic prescribing across the UK, we now really need to urgently move away from paper assessments to electronic assessments. And I'd like to thank, obviously, a number of individuals that are involved in this. I'm happy to take any questions.
Thank you for a really nice presentation. I'm Steve McWilliam from Liverpool. Do you think, given the sort of performance of your new F1s in your prescribing sort of assessment, do you think that kind of the current sort of PSA is not necessarily preparing them as well as it might be for actually prescribing on the job?
I think the two things are quite different. When we were looking to introduce this assessment, the regional prescribing assessment, back in 2011, we thought it would only be for a few years because the PSA would come along and this wouldn't actually be necessary. What we found is that the two were actually quite different, and we didn't necessarily see any reduction in serious errors as a result of the trainees coming in having done the PSA. So the two assessments are quite different. So that's why we've carried on using the same. We do ask our trainees, have they passed the PSA? And so we will be looking at that as to whether that does make a difference.
Yeah. Do you think we're concentrating on the serious errors, with the training that we're providing in medical schools then, which is now more focused towards passing the PSA?
I don't know. I'm not sure really. Yes, I think that's difficult to comment on.
Perhaps our next speaker could bring light to that.
Yes.
Okay. Thank you very much. Great talk. Good results. It's my distinct pleasure to show our next speaker, Dr. Simon Maxwell. So Dr. Maxwell qualified at Birmingham, trained in the Midlands, and has been in the University of Edinburgh for quite a while since. And he's been a national/international leader in the introduction of the PSA, Prescribing Clinical Assessment exam, an exam piloted here in Scotland, and then expanded across the UK and now in 18 different countries? Lots of different countries. And we're going to get insights on how the PSA works from an international perspective. This is a global talk, which is good. So Simon.
Yeah, it's going to be a global talk with a UK emphasis, I think. We'll put it that way. Thank you very much to everybody for inviting me to give this talk. So I'm going to very briefly talk about the clinical problem, which I suspect my predecessors have talked about, the educational challenge, what we've tried to do in the UK, and get on to the more global aspects. I think everybody recognises medicines are absolutely key to what the healthcare services do around the globe. It's how we treat disease, prevent it, alleviate symptoms, and most of what's going on, I think, is good quality, but unfortunately there's a measurable error rate, 10% we reckon in UK hospitals, certainly about 10 years ago, 5% in general practice. We've also got a lot of people appearing at the front door of the hospital as a result of adverse reactions, many of which could have been avoidable, and if you get into hospital in the UK, you've got a big chance, 15% or so, of having your course of healthcare altered by an adverse reaction. So if we're looking towards potential areas where we can improve the quality of healthcare service delivery, then medicines are where it's at. And of course, it isn't just the UK, although we do tend to obsess about these things a lot. Actually, the global burden is enormous, and importantly, it falls particularly heavily on resource-poor parts of the world. We shouldn't be surprised that things often go wrong. In my view, it's the most difficult thing we try and teach our graduates to be able to do, to have a case diagnosis in front of them. Sometimes the diagnosis is uncertain. Choose a medicine, dose, route, frequency, and duration, but do so recognizing the infinite variability of the patients we deal with. And then they've got to interface increasingly with patients who expect to be told more about their medicines, and of course sometimes it's vital to the success and the outcome. They've then got to know how to monitor things. So there are so many places things could go wrong in that process, and so many challenges to be able to do it well. And we have to recognize that the younger people in the audience who are working clinically they've got more of a challenge in getting this right than probably we did 40 years ago when I graduated, for a whole host of reasons. Most obviously the aging population, the increased vulnerability of the people we serve, but also the fact that they take many more medicines. So trying to dig into what's is the seat of the problem. So 15 years ago, a number of studies, and I've saved you the reading by actually summarising, at least from a UK perspective, what they said. And that is, firstly, it's clear that in UK hospitals anyway, it was junior doctors, recent graduates of our medical schools, who were doing a large proportion of the prescribing. They felt underprepared to do that. They didn't get any practice during their training. We've already heard from Lionel, how appalling the figures are, really, given that when you walk out onto the wards first day, you could easily write 20 prescriptions, depending on sort of which unit you're working in. It's the part of the job they feared the most, and it's the part that their trainers, the people who supervise them, feared was not really represented properly in undergraduate education. So this just is an outline of a sort of potential career ahead of a graduate, career stage, graduation, and then trained as a senior doctor. And up the y-axis, you've got the level of task that can be entrusted to those individuals. And I think we'd all agree there must be a basic level at which you don't want people walking out as junior doctors or residents onto the wards. And really what a lot of the previous surveys were showing us was that our graduates, or at least many of them, were not getting there, and that the learning curve was too steep, too late in undergraduate training, and actually a lot of that learning curve was taking place on the wards in front of patients. And what we really, I think, all aspire to try and do is make it a more gradual learning curve that actually reaches basic competence at the time you're in a sort of patient-facing role. So all of the stakeholders fortunately got together about 15 years ago and generally were agreed something needed to be done. The top three are the most important. We had to agree on what the outcomes of undergraduate education should be in relation to medicines. Unbelievably, that was not agreed. Not everybody was singing to the same hymn sheet back then. We needed a national e-learning strategy to support the great work going on in medical schools. But critically, we needed a reliable assessment at the end to make it clear that there was a point where graduates would have to demonstrate that they'd met those learning outcomes, and that the schools that were training them would have to demonstrate that that was the case. So it's a classic educational pathway. Define what you wanted to get to, provide the pathway, and then make sure that that path has been travelled. In blue is simply the bits the British Pharmacological Society has helped with, but really it was clinical pharmacologists, I have to say, largely in this country, I think, who were complaining, I suppose pharmacists as well, but particularly clinical pharmacologists, that we had to get this right and do it better in medical schools. So very briefly, those were the outcomes which were published, firstly by the British Pharmacological Society, but embedded largely in what the GMC, the regulator, was asking, a competency framework which covered all prescribers now that we recognise that pharmacists and nurses are also increasingly prescribing. I think we need to foster better environments in our medical training. It's absolutely critical, I think, and there are many people in this audience who are those people showing leadership and visibility, the fact that medicines are important. The learning burden is enormous, so student formaries are critical. But it's very important that we get people away from the idea that cold lecture theatres are actually going to get people over the line here. They have to be seeing what's happening practically, and as far as possible getting involved in that practical activity. So we produced e-learning modules that we called Prescribe. We built a prescribing simulator, which is case-based, and then you write your prescription electronically. We did this about 12 years ago. You write your prescription and you get automated feedback. And it was really that principle that led on to us developing the prescribing safety assessment. So the prescribing safety assessment, a collaboration between all the medical schools in the UK and the British Pharmacological Society. When we started in 2010, The key important reasons for doing this were clinical governance. We wanted people who were going to walk out of medical school and be reasonably safe to practice, but also educationally, it's important that institutions knew whether they're actually doing a good job or not. In our view, there was no thing to pull off the shelf or international example of what we were trying to achieve, so we started with a blank sheet of paper, essentially. But we decided this had to be done nationally. No medical school, no hospital, or even region has enough resources to produce a high quality, reliable, international standard assessment. So this had to be collaborative to bring in the resources. The principles were simple. You have to pass it before you start work and walk on the ward. It was meant to be about real clinical cases, obviously in a simulated environment, but real clinical cases, not just a simple multiple choice assessment. We decided to do it online, which was controversial because, as has already been said, a lot of our prescriptions are written on paper, but it was a prescient decision because it meant we could easily deliver this assessment all around the country and now all around the world from a central server. We decided this was going to be open book, as any clinician has the resources to look up. This assessment was going to be open book, and wherever possible it was meant to be about skills, deductive powers, a little bit of grey case rather than simple cookbook answers out of the British National Formulary. So some of you will already be familiar with the setup. 40% of the marks go on prescribing, another 16% on prescription review, and then the rest of the sections, which we think encompass most of the things we expect junior residents to be doing in our hospitals, are picked up in those 8 systems, and our questions are nested in all kinds of clinical practice, but particularly medicine, elderly care medicine, and general practice. So we all deliver it all from a sort of purpose-built system. This is where all the authoring, editing, QA goes on, and it's from there that all the participants get their accounts and take the assessment from. We've got about 4,000 items now written by our trained team of authors. All of our items go through a very detailed QA process, because if you're going to put items in front of large numbers of people, you expect that a lot of eyes have got to have seen them. So our question writers are senior doctors, junior doctors, but also pharmacists who've stepped in really very enthusiastically from the start, maybe because many, like Naomi, were sort of dealing with assessments and the kind of problems that are faced when things go wrong in hospital. So the delivery happens every year. It's all UK medical students. It's now about 8,000 most recently. So before they qualify and start prescribing, all 34 medical schools. We've also include now the Irish medical schools and Maltese medical schools, indeed have done for several years. Before anybody sits this assessment, they get 4 practice assessments. So by the time they even step into the assessment, they've already written about 30 practice prescriptions, even if their medical school hasn't got them doing that. We have 200 events all around the country every year, spread over 4 days. So rapid turnaround and marking. It's electronic, so we could assign a mark when they walk out of the assessment. But of course, many of the prescriptions, we have 100 possible right and half right and wrong answers. But just occasionally, if 8,000 people are taking a question, somebody's going to write something which actually, on reflection, the assessment board thinks does deserve a mark or 2. So there's a delay of 2 weeks while we just sweep through those before issuing the marks. And there is, of course, a feedback cycle. So briefly, this is kind of what it looks like, the assessment system. So this is the prescribing tool, online predictive texting, drop-down menu. Same with the doses. then you've got your full prescription, you move on to the next question. So this is a prescription review question, because of course our junior residents review many more prescriptions than they actually write themselves, so a critical part of the job. This is just to show that the tools provide you abbreviations. They'll open up the British National Formulary. They will also provide you with a calculator as well, if needed. Although most of the calculations questions, frankly, for anybody who went to school before 1990 can do them in their head, really. So, and there's an assessment dashboard there, so at any moment they can see where they are, which questions they've marked they want to go back to. So what's the outturn? Well, last year, around about 8,000 students. You can see that we have 4 assessment days, so the vast majority sit the assessment, or the large majority anyway, sit the assessment on the first assessment day. So you've got to have a server of some capacity and capability to deal with that many people interrogating at the same time. So we have had a few failures in the past, but we've now, I think, worked out, and it works very reliably. There's a few more medical schools do the assessment in March, April, and by the time you get to March, April and June, you're starting to have some resits coming through. 95% pass. Cronbach's Alpha, I think, meets international standards, as does the standard error of the mean. And, with respect, I think you've got to do something at big scale if you're going to be able to get a cohort of reliable questions. So this is a whole feedback cycle. We feed back to the candidate, so this is a candidate account, so they get to see their score in the assessment broken down by area. But of course, in a real candidate's account, they've got several practice assessments there as well. And when they click on the practice assessments, not the summative assessment, the pass-fail one, when they click on the practice assessments, having done the assessment, they can then go through question by question and see what they scored overall, see the individual components that made up that score, and then get some focused feedback. And so, I think the important thing here is, of course, it's important it's a pass-fail assessment at the end, but that isn't the most important part of the process. It's practice, feedback, and learning. And I think this is a much more important tool as a learning tool, really, more than anything else. So this is the performance by medical school. I'm sort of pleased to be able to announce that both Edinburgh and Brighton are sort of well over to the left on that graph, but you can see how powerful that is. There are 2 schools there who I think have joined us relatively recently who have not performed as well as the rest, and it's really important that they can see that, not to sort of give them depression, but actually because educators should understand whether actually what they're doing is proving successful in relation to peers. The candidates' feedback to us, of course, and you can read the questions for yourself. The one thing they don't like is that it's a time-limited assessment, strong agreement on the right and a strong disagreement on the left. So you can see the one that's going the wrong way is that they're not that happy about. It's a relatively time-limited assessment. But on all other criteria, I think it's proved very acceptable. In relation to what others have been saying, particularly Lionel, just look at the bottom right, number of prescriptions written before coming up to the end. Getting better, but a third still ticking the box 5 or fewer. I mean, that shows you there is still a lot to be done, but I'm pleased to say there are many more ticking large numbers of prescriptions. So what have we achieved? An online assessment system, large numbers, can deliver to large numbers in multiple locations. I think we've got quite a big bank of high quality assessment materials, automated marking feedback, but it's the interactive learning part of it which I think is the most important. And can't speak for Kent, Surrey and Sussex. I'd be interested to see your data, but the national data sets suggest that actually error rates are going down the way. And of course, there are other reasons that might be, but I think in general, the rate it's had some impact, and I hope there'll be a publication shortly that shows that. So what's the future for us? Obviously, senior doctors and CPD, but there are new prescribing groups coming along, and we hope we're going to have a very strong dialogue with the pharmacists as they upskill and try to sort of produce more prescribing. One of the best bits for me has been the international collaboration. Kelly's in the room, Mike. It's been great collaborating with other countries. We've got to a bit of a stop-start with Canada, but I hope we're going to. But I think in Australia and New Zealand, things seem to be going from strength to strength. The one omission there, or one important omission, I should say, is the Stars and Stripes. And Lionel, what we really should be discussing this. I have worked so hard to try and get colleagues in the US interested in this, because I think you're struggling with exactly the same issues we have been. So I hope that might happen. There are, of course, internationalization issues, language, the language of medicine itself. Nobody talks about the ER where we are. Medicine names sometimes differ. Prescription terminology differs. But these can be overcome. You just need an enthusiastic group of editors, as we have in Australasia and as we had in Canada for a while. And you can overcome those. The principles are exactly the same. We've had the great benefit that we do have a British National Formulary, and it's interesting, as I've sort of spoken to others, it's amazing how lucky we are to have a formulary that everybody uses because you've got to have something to root the right and wrong answers in. That's absolutely critical. So we've got the BNF and we've got the NICE, which has been great. And I think Naomi's talked about paper versus electronic. So there's sometimes some external validity issues. And I do accept that local assessments sometimes could do and test things the way they are locally. But I think given the cost effectiveness of delivering this at such large scale, I think really this is a process that certainly, I would encourage you to emulate, even if you do it a slightly different way. I won't push the summary, but I do need to acknowledge that although I get to talk about this very frequently, there are an enormous number of people who've brought the process in the UK with a prescribing safety assessment, or skills assessment as we brand it internationally, to where it is. And for anybody who's interested, the last slide, which I'll just leave there during the Q&A if there are any, is just a QR code. You can go there and you can see what we're up to. There's just a free set of assessment questions you can go in and try for yourself. Thank you very much.
Time for a few questions. Anyone? Up here in the front.
Thanks, Simon. Kelly Charles from University of Sydney. If anyone wants to know how we internationalised our PSA over the last 5 years, we're happy to chat to anyone. It's been a really very positive experience working with BPSA, Simon and the team. My question, I guess, is back to educators. So probably very similar to Lionel and Naomi, when we see our internal assessments where we can see where the students are going wrong, it allows us to feed back to prior educators to say, hey, this is an area that students are really struggling with. Insulin is a classic example. It's a really hard area to teach and to get it right so students feel fairly confident. It's something you need to do lots and lots to actually do it well. But I'm wondering, from the PSA, we give some feedback back to the students, but is there an ability for you now, as you've run it so many times, are there question types? Are there question topics, content areas that we as a group of educators need to maybe focus a little bit more attention on to sort of upskill our students as they're going through? So it's kind of now starting to become a feedback loop to the education community.
I know Michael will want me to be very brief in my response to that. Yes, and if I was to criticise ourselves, well, there's a lot we can criticise ourselves for, we probably haven't done enough of that feedback from the central operation. Obviously, We recognize that managing data and interpreting data in relation to medicines is a problem. Everybody finds those questions difficult. Some schools were finding the calculations difficult, and that's why I highlighted that, so we fed that. But when it comes to specific therapeutic areas, I think you're absolutely right. We probably could have done better to say, these kind of questions come up all the time, they're not performing well, and try and get the message out. And I have to say, we haven't done that, other than it happens within our author group, and they, of course, represent quite a lot of different medical schools. So maybe the word filters back that way. But it's a very good point. But it's a tool that can allow you to do that if there's someone there and there's enough time. And I'm sure you're discovering that in Australia.
A bit from undergraduate to postgraduate, and it's my pleasure to introduce Ali Hossein, who's qualified at Imperial College, trained at Geisel and St. Thomas, and now is the chief registrar at UCL. He's going to talk to us about the perspective on postgraduate, security alert, postgraduate education with respect to clinical pharmacology. It's things that varies country to country, but certainly be interested in how things work here in the United Kingdom. Ali.
Thank you very much for the introduction, and thanks to the organising committee for having me today. And most importantly, thank you to all of you for sticking it out for the graveyard shift. I wanted to start by providing an overview of sort of clinical pharmacology training in the UK, and then followed on from that, discuss the impact that COVID-19 has had on our training, and then discuss briefly the new curriculum that's been implemented, as well as, importantly, offer the trainees' perspective from a personal level, a local level where I practice in London, and a national level. And then sort of present an argument for the need to evolve and sort of why that needs to happen, and some ways in which we might be able to do so. So starting with an overview of clinical pharmacology, mindful of the international audience we have here at WCP 2023, so just to briefly run through it. So it's a postgraduate medical specialty for medically qualified individuals. Its entry takes place after sort of foundation and core training, which are sort of rotational jobs across medical specialties. And it's a small specialty. I think this is important. There's around about 50 trainees in the UK, and about 120 or so practicing consultants. And this is a sort of a national picture. The green circles that are filled in are where there are currently trainees in clinical pharmacology. The green circles that aren't filled in are where there are practicing consultants, but without trainees in those areas. And this becomes important a bit later on. We have a reasonably large footprint across the UK, but could be better perhaps. So this sort of illustration shows, well, firstly, the length of postgraduate medical training in the UK, a lot longer than perhaps in other countries, but also where clinical pharmacology fits into all of it. So after medical school, after graduation, there's the foundation program and stage 1 of internal medicine training, where doctors rotate through various medical specialties. And then after 5 years altogether, that's when they enter clinical pharmacology specialty training, which is a 4-year program, which is dual accredited with stage 2 of internal medicine training. So the end result is a consultant who's qualified in both clinical pharmacology and internal medicine. There are other entry routes as well for clinical pharmacology training, such as through integrated academic training, sort of slightly earlier on, which afford trainees protected time to do research alongside their clinical training. In terms of career destinations for clinical pharmacologists, well, broadly, clinical pharmacologists tend to practice either in clinical medicine or academia or industry, or a combination of the three. And this is some research which some of you may be familiar with from Professor Aronson from 2012, which sort of highlights the average time split of a clinical pharmacology consultant, where there's a roughly equal split between clinical work and research, which take up the majority of a clinical pharmacologist's time on average, and then smaller but still significant amount of time spent on other activities such as teaching, policy work, and writing. So next I wanted to talk about the impact that COVID-19 has had on clinical pharmacology training. Well, firstly, clinical pharmacology trainees were redeployed sort of en masse. Many of us received emails not dissimilar to this one, sort of around the first wave of the COVID pandemic, where we were sort of pulled away from our clinical pharmacology training and moved to sort of contribute to the fight against COVID-19 through manning or staffing COVID wards and rapidly sort of learning how to use ventilators and so forth. Just trying to advance my slide. And so there was loss of clinical pharmacology training time through cancelled clinics, so cancellation of research time, and for those of us who were working in clinical trials, recruitment sort of came to a halt, and many sort of trial sort of protocols and follow-up visits were also halted. But at the same time, clinical pharmacology came to the fore in that we were able to apply those clinical pharmacology principles that we were trained in through contributing to recovery and other trials as either co-investigators or helping with recruitment and data collection. There was the COVID Therapeutics Advisory Group, which was sort of developed by clinical pharmacologists, where we contributed to the evidence base for what was at the time a sort of wild west of non-evidence-based therapies that were used, at least in the first instance, for COVID-19, as well as other local research initiatives. So, for example, locally, we contributed to data collection for evaluating the role of non-invasive ventilation in COVID-19. Now, there are a few ways which I wanted to briefly kind of highlight through which the adverse training impact of COVID-19 was reduced. So one is through the introduction of new appraisal outcomes, which sort of recognize in the trainees' annual review that their training may have been affected by COVID-19. And these are two of those at the bottom of the slide, that two possible outcomes that are COVID related that kind of may allow a trainee to progress but recognize that their training has been disrupted. And as well as that, there were national training recovery initiatives and funding through organizations such as Health Education England. And as well as that, I think the sort of trainers and consultants and training program directors locally should be recognized as well in providing sort of local support and remedial processes for individual trainees that may have been affected by COVID-19. And I wanted to also highlight the role that our national society, the British Pharmacological Society, has played in sort of maintaining our training as clinical pharmacologists throughout the pandemic. So July 2020, our virtual training not only went virtual but also went national. In that previously, prior to COVID, we had sort of locally organized teaching and then one sort of national teaching a year. But now it takes place monthly and with a rotation across the UK of different sites taking turns to host it. And I think the BPS have been hugely instrumental in the success of this through sort of organizing it, sending out the meetings and sort of letting us use their platform to host these talks for review at a later date. And then not only that, but we've also thankfully been able to meet face-to-face again, and in some instances for the first time, through some national training which have taken place in Birmingham, London, and of course here in Glasgow. So onto the main body of this talk, which is training the next generation of clinicians. Well, firstly, there's the new curriculum that's been implemented, and the new curriculum there's been a new curriculum for clinical pharmacology as well as for internal medicine. Now, internal medicine training has now become a 3-year program, and it's meant to give doctors sort of key sort of physicianly skills to equip them with the competence and confidence to become the medical registrar and managing the acute medical take. And it mandates experience in looking after sort of acute and chronic conditions in the inpatient and outpatient setting. And it mandates experience in intensive care, geriatric medicine, and outpatients. And so this is where it sort of fits in. It used to be sort of core medical training, which was 2 years, followed by 5 years of clinical pharmacology training. But then with the introduction of the new internal medicine curriculum, those generic skills acquisition years take place over 3 years, followed by 4 years of clinical pharmacology specialty training. I suppose the end result of that is sort of a net loss of 1 year of clinical pharmacology specialty training. And so that combined with the sort of the COVID impact that training has had means that sort of trainees and trainers need to work sort of collaboratively to ensure that sort of we can become the best clinical pharmacologists that we can be in spite of those challenges. I'm just going to try and advance my slide again. Right. And so this is the sort of the new curriculum, which takes the form of 7 sort of key capabilities in practice. I won't go into them in great detail, but I'll just sort of highlight that through the internal medicine part of our training, we can address these curriculum competencies in a number of ways. For example, we see adverse drug reactions quite commonly on the acute medical take, as do we overdoses. We are increasingly looking after patients with multimorbidity and polypharmacy with an aging, increasingly complex population that we serve. And so essentially, the next sort of latter part of my talk, I want to bring in the trainees' perspective sort of from a local as well as national point of view. So wanted to briefly kind of sort of convey some key messages. One is that the COVID disruption is improving. So this was from a survey of London trainees in March 2021, where sort of the blue bars that skew towards the right indicate agreement with COVID disruption. So for example, training being disrupted by COVID, so trainees not being able to meet curriculum competencies, not being able to attend teaching and so forth. And the same survey conducted a year later showed that seems to be improving, with sort of fewer trainees reporting that sort of disruption. The second key point, which has been fed back by trainees, which seems to have been consistent over the 2 years of the survey, is that toxicology is an area which trainees feel that they don't easily have access to and training in contrast to hypertension research and clinical trials, which trainees do feel they have easy access to. And so that's something that could be kind of improved by introducing rotations to a toxicology centre, secondments and so forth. But I think crucially, and the third point that I wanted to convey through the results of this survey, is that trainee satisfaction is high. Overall, trainees are happy and are glad to be kind of training in this specialty. There's often kind of criticism of London trainees that we're sort of very London-centric, and there's the sort of the London arrogance. So we'll try to conduct another survey to bring in the kind of national perspective. And so this, what I'm about to show you is a word cloud from trainees surveyed from across the UK in preparation for this talk. And I asked them, if you could describe your CPT training experience in one word, what would it be? And so the larger the word, the more commonly it featured. And I'm going to try and show it to you now, but it's not coming up, sorry. There we go. So you can see sort of some key words which I wanted to draw your attention to: opportunity, adventure, supportive. There were a few sort of less positive words like turbulent and disappointing, but thankfully the font size was smaller for those words. And then sort of finally I wanted to spend a few minutes to present my argument for the need to evolve as clinical pharmacology trainees and the need to evolve as a specialty. And I'll present a few thoughts on why this needs to happen and how we might be able to achieve this. So this is a meme which I found on the internet, posted by an anonymous Twitter account called Meme Consultant, which sort of highlights a sort of an attitude towards clinical pharmacology that is still present, which asks the question, clinical pharmacology is still a specialty? And well, I mean, it's evident through this week and through kind of the sort of national and international pharmacology community that it very much still is a specialty, and it is alive and kicking. And there are many ways in which we can try and continue to allow it to remain a sort of recognised postgraduate specialty in the UK. There is a great risk through unfilled posts that we may lose training numbers and that the specialty may get smaller, at least in the UK. But yeah, I'll try and explain how we can try and address this in the next slides. So one way that we can do this is providing earlier exposure to clinical pharmacology. Now, of the national trainees that were surveyed, all of them didn't decide to become clinical pharmacologists until after they had graduated. And this may in part be related to when they encountered clinical pharmacology and therapeutics as a specialty. The majority of them encountered the specialty in either the latter part of medical school, so their clinical years, or after graduation. And so how can we sort of expose trainees to clinical pharmacology earlier? Well, it's through clinical pharmacologists becoming more involved with preclinical medicine training, curriculum design and delivery, through offering intercalated BSc programs in clinical pharmacology. I think there is opportunity for improvement in that latter domain. For example, I know of at least one major London medical school which is no longer offering pharmacology as a BSc, as an intercalated BSc option, which when I discovered, I found quite astounding. And just to add a sort of personal perspective, the turning point for me for sort of wanting to be a clinical pharmacologist was 11 years ago. This was the BPS Winter Meeting 2012, where I was fortunate to have been able to present my intercalated BSc project, which was supervised by Professor Jay Mitchell, which many members of the BPS will know. And it was really the kind of the collaborative, forward-thinking, inclusive community of the BPS and the sort of other affiliated pharmacological societies that made me want to be a part of that team. And so it is a real privilege for me to be standing here to kind of talk about my clinical pharmacology experience 11 years later. And so how else can we expose sort of medical students and junior doctors to clinical pharmacology and encourage them to train in the specialty? Well, by offering sort of clinical pharmacology electives, and also introducing more foundation and internal medicine training rotations in clinical pharmacology. So imagine if we can sort of turn these sort of green circles that aren't filled in into green circles that are filled in. Wouldn't that be a great thing? And we can do that by sort of responding to calls from Health Education England and sort of the other sort of healthcare education organisations for new rotations and sort of committing to bringing junior doctors in to train in clinical pharmacology at local centres. And then the second thing I wanted to kind of, postulate was the role that clinical pharmacology may play in novel therapeutics that are emerging. Obviously, the T stands for therapeutics, and there are sort of digital therapies that are emerging, such as sort of technology-enabled remote monitoring, artificial intelligence, and so forth. And although we don't regard these as pharmacological therapies, they have arguably just as much potential to alter human behavior, physiology, and patient outcomes. And they're being rapidly deployed into clinical practice with less of the sort of evidence-based approach that we're familiar with. And I would argue that we as clinical pharmacologists, through our robust training in experimental medicine, clinical trials, and so forth, are in an ideal position to sort of evaluate these technologies. And this comes alongside a crisis in doctor retention that we're seeing in the UK. Increasing numbers of doctors are leaving after their foundation training and leaving medicine altogether. Many of them take up roles in data science or AI or tech. And sort of if clinical pharmacology leans into these sort of novel therapeutics and offers sort of dedicated training in that could be one way to help to address that crisis that we're seeing. The other way, and this is kind of my final kind of point I wanted to make about how we may increase clinical pharmacology's kind of visibility and footprint and sort of encourage more people to train in the specialty is through knowledge exchange. We should offer more fellowships in clinical pharmacology or even exchange programs. Now, fellowships are sort of common in surgical and procedural specialties, orthopedic surgery, cardiology. One of my friends who's an orthopedic surgeon is sort of making plans to conduct an orthopedic surgery fellowship for a year in Canada. Why don't we introduce more of these in clinical pharmacology? There is evidence that shows that these fellowships, at least in surgical disciplines, are not only sort of on a qualitative level a valuable experience for trainees, but have also been shown to improve patient outcomes in centres that offer fellowships versus those who don't. And again, sort of if we kind of bring this into the global sort of lens, imagine if we can populate this world map with clinical pharmacology training centres that offer sort of fellowships, rotations, exchanges, secondments, so that we can sort of build on each other's strengths and learn from each other and share best practice. Wouldn't that be a wonderful thing? And so to summarize, I wanted to essentially convey the messages that clinical pharmacology training in the UK presents opportunities as well as challenges. COVID-19 has been a barrier, but also a facilitator of our training. Trainees overall are happy, and that I think the specialty can do a number of things to try and expand and broaden its remit and retention of junior doctors through earlier exposure to the specialty, through embracing sort of training in technologies such as digital healthcare, as well as international initiatives. Thank you very much for your attention.
So I couldn't help but notice the strong mention of internal medicine. Speaking of someone who actually is a pediatrician, how does that work for non-medicine specialties in the UK?
That's a really good question, and there is some sort of context to it in that until a few years ago, trainees were able to dual accredit in clinical pharmacology and other specialties such as pediatrics, gastroenterology, dermatology, infectious diseases, but that's changed. in that now, in order to pursue clinical pharmacology as a new entrant to the specialty, it's mandated that you dual accredit with internal medicine. And whilst this is good in terms of building those kind of core physicianly skills, I think it may potentially dissuade people who are interested and invigorated by clinical pharmacology but have other interests beyond internal medicine.
Yeah, so I can again add perhaps the international perspective on that. So in Germany we are facing also a serious paucity of students who finished medicine who would like to become either clinical pharmacologist or experimental pharmacologist. So we have a very serious discussion what we're going to do with our disciplines. So nationwide, we have perhaps at best 5 to 10 people specializing. So it's getting more and more difficulties. I mean, in Germany, it's a big country to find places where people can train. And so some of the suggestions that you had are really good. And I think we should team up at finding solutions for this. We're still early in the process of doing things. And, in some areas, Germany is very slow. But we are facing the same problem. And we can say that in principle there is interest of the students in pharmacology, but we have to change what we are offering in terms of content. This is very clear to me.
Interesting to hear that international perspective. Yeah, thank you.
Great. Lionel?
Yeah, sure. Thanks for a really nice talk about what's going on in the UK. 2 points. In your suggestion with fellowships, which I totally support, one of the difficulties is that for medical graduates from the UK to be clinically involved in the US, they're going to have to go through the US exam system. So they're going to mainly focus on research aspects. So just a sort of point of operational. The second question really is to do with the issues surrounding the clinical pharmacology training in the US and the UK. We too are suffering from a paucity of youngsters in coming forward. And I think one of the aspects we need to think about is really what some of the fellowship programs are doing in the US, which is maybe combining clinical pharmacology with another discipline like oncology or GI or something. And although it means you're going to train for longer, you're going to be really specialized in both those disciplines. And I don't know whether the UK has thought about doing that.
Yeah, that's really interesting to hear about the sort of the logistical barriers to international training in terms of licensing. But yeah, I completely agree that offering clinical pharmacology alongside another specialty, an organ-based specialty or a craft-based specialty, could help to kind of attract the next generation of clinical pharmacologists. And in fact, it used to be the case in the UK, but unfortunately the General Medical Council no longer permit that as an option. I'm not sure what the exact reasons are for that, but I suspect that with a shortage of sort of internal medicine consultants, I think there's a drive to kind of get more physicianly trained people coming in, and for that reason, it's no longer a thing.
Two observations. First, Canada does not have that problem the US does, so you can come train in Canada. But second, actually in Canada we don't have quite as many trainees as you do, but our model actually is more to the actual dual training. So for our training program in London right now, we have there's 3 fellows. One's a person doing general peds and clin pharm. One is a person who's qualified in medicine, is doing critical care. And one's a person who's doing medical oncology and clinical pharmacology. So most of our trainees are actually qualified in medicine and then do something else. And I think that's the only viable model, at least for our country, to move forward, because we have some GIM people, we always will have some. But I think the majority, like Lionel says, are people who come in, I want to be an oncologist, but I want to learn about phase 1 trials of drugs. I want to be a rheumatologist, but I want to learn about pharmacology and biologics. And I think that's actually, at least for us, that's the future.
Great.
Can I just make a final comment? So as a pediatric clinical pharmacologist, so just put my hand up, there is still a pediatric Clin Pharm training pathway in the UK. We go into paediatrics first and then subspecialise. But just to come back to one of your points earlier about medical students not being aware of Clin Pharm at all as a specialty. So one of the things we're doing in Liverpool with our training is getting some of our more famous clinical pharmacologists. So we got Munir in to speak to the first years, just to kind of talk about his career and kind of what Clin Pharm is, alongside our kind of basic sort of PK/PD lectures. And out of that generated quite a lot of interest from students. You know, what is this specialty? How do I find out more? So just trying to link that back to, you know, really trying to enthuse students for Clin Pharm at an early stage in their careers. Thank you.
Thank you.
With that, I'd like to thank, great talk, Edward. I'd like to thank our speakers today.